This meeting is now being recorded.
Well, good evening. Welcome to our EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, I'd like to give an overview of our free program to those attending for the first time. So we're going to go over who we are, what is our program, some upcoming events, then introduce Dr. Richard Barnum, our speaker for this evening, and then we'll have a Q&A session after that. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away of breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their community. We've started over 60 groups to date. Each group is given their own free website with a link from the directory in the map. We receive feedback at the conferences that they provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive free announcements, email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you will find over 250 products selected by EDSers for EDSers. The store is the only funding for this program, so to continue the program, please visit the store. We have a variety of products, including braces and pillows and a number of interesting products that you may not find elsewhere. So visit the store, and that's what supports our program, and typically it covers our monthly web feeds. So just a disclaimer, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
And upcoming events, our speaker for October 1st is Kathleen Kane. Kathleen is a disability attorney with EDS experience and also the wife of one of our connective tissue disorder advocates. And she's going to talk about applying for disability. Another event, just to make people aware that September is Pain Awareness Month in several U.S. cities. Read the article on our website about the awareness event on September 27th, located in Providence, Rhode Island. And visit the uspainfoundation.org to get involved. Just a reminder, after tonight's presentation, there will be an opportunity for Q&A. Add your questions at any time during the presentation by clicking on the Q&A icon located at the top of your screen. After typing in your question, click the orange button to submit. Our speaker tonight is Dr. Richard Barnum. His topic is dealing with diagnostic controversies in psychiatry and medicine. Unfortunately, many EDSers are misdiagnosed with psychiatric conditions before their Ehlers-Danlos, dysautonomia, or associated physical conditions are identified. Families are eager to learn about how to handle situations where they feel misunderstood by their healthcare providers. And I just wanted to caution that some of the content may be intense or have emotional situations and may not be suitable for children or younger audiences. Dr. Barnum addresses what can happen in extreme situations that escalate out of control and how to avoid these situations. He will explain diagnoses such as conversion disorder and Munchausen syndrome by proxy. And some background about Dr. Barnum. He is a child and adolescent forensic psychiatrist. He directed the Boston Juvenile Court Clinic from 1982 to 2003 and was formerly on the faculty of the University of Massachusetts and Harvard Medical Schools. And he's written on issues of forensic assessment of children and families and mental health concerns in the juvenile justice system. Since 2003, he has been in private practice providing consultation and treatment for children and families in community and residential settings. He is very passionate and empathetic to children suffering from various hard-to-diagnose medical conditions. And he has spoken at conferences such as the TCAP, which is the Coalition Against Pediatric Pain, and his articles have involved a focus on EDS. Just a note that Dr. Barnum has written a great paper presenting the case of a child with EDS who had been previously diagnosed incorrectly with a conversion disorder and referred to mental health care. We will provide a link to this article, which will be found along with a recording of the presentation on our website. So at this time, I wanted to welcome Dr. Barnum. We're looking forward to your presentation, and I'm going to go ahead and turn over the microphone to you. Thank you so much.
Thank you very much, Deanna. Those of you who are familiar with the news will recognize the picture here. Those who are not, this is a picture of, I'm sorry, where's the arrow? Here we are. This is a girl named Justina Pelletier who is photographed here after having been released from the custody of the Department of Children and Families in Massachusetts and allowed to return home to her family after over a year of forced separation and treatment. I'm going to be talking about this case a little bit, even though Justina does not have EDS. She has mitochondrial disorder. But the point of this is that what I'm really talking about here is not so much EDS specifically as it is conflicts over complicated diagnoses and how to understand them and how to deal with them. So I'm going to just talk briefly about Justina's case for background and then move more explicitly into, where's that arrow? Okay, sorry. More explicitly into problems of diagnostic controversy and some specific aspects of EDS that tend to contribute to the vulnerability that people have to this kind of controversy, and then offer some recommendations for doctors and for patients. Again, as Deanna said, most of my work is with children and adolescents, so this is primarily focused on issues that have to do with children and adolescents and their parents. I'm sorry, I keep going to the wrong arrow. This arrow up here is the one. Okay, so Justina was a 15-year-old girl who had a long history of mitochondrial disorder with a wide variety of different kinds of symptoms. She was in treatment with an excellent, experienced team of doctors at the Tufts New England Medical Center. She had the bad luck that the GI specialist that she was working with at Tufts left Tufts and moved to Children's Hospital. And so in February, Justina was referred by her doctors at Tufts to Children's in order to be able to maintain her relationship with him and have him attend to the problems that she was having in her GI tract. when she went to Children's, something strange happened that I don't really understand. I just want to sort of insert something that I should have said earlier, which is that I've never met Justina or her family. I've had no involvement with the case. Everything that I'm talking about is straight from the newspapers, and so this is all public information. Somehow it happened that she was not actually seen by the GI specialist when she got to Children's, but she was seen instead by somebody else who was struck by the impression that the symptoms that she was having couldn't really be completely explained as a result of her mitochondrial disorders. And so whoever this person was, or people were, I'm not sure, tried to present this information to the family. The family became quite defensive about it. The staff wasn't really very successful at all in engaging the family or having a productive conversation about the difficulty, the controversy, the actual condition, and ultimately the staff at Children's reported Justina's parents to the Massachusetts Department of Children and Families, which is the child protection agency in Massachusetts, with an allegation that they were contributing to Justina's medical problems in some way that is not entirely clear, but which is sort of thought of as medical child abuse. I guess what that really means is that we were in some way sort of behaving oddly and fostering illness behavior in her, but it's not at all clear. At any rate, things went from bad to worse, and Justina was ultimately committed to the State Department of Children and Families, and on the recommendation of the staff who were working with her or trying to work with her and not really being very successful at Children's, she was placed in the Children's Hospital Locked Psychiatric Unit for treatment on the theory, I guess, that somehow what was wrong with her would get better as a result of her being locked up in a psychiatric hospital some time with depressed and anxious suicidal teenagers. She stayed there for over a year without really changing very much at all, and languished essentially without anybody paying any attention, as far as I know, until there was a long series in the Boston Globe last spring that was probably the result of her parents going to reporters and saying, look, this case is crazy and people need to know about it. But I don't know that for sure. It's just that that's the only way that I can imagine that the detail of information that was in the series would have gotten to the newspaper. In any event, there was an enormous outcry from all kinds of quarters about how terrible these events were, and this slide is just a selection of images from the internet having sort of reflecting the breadth of interest and concern that arose in all different quarters that really had not very much to do with mitochondrial disorder or medical illness or medical child abuse, but a lot to do with questions about parents' rights, family rights, government intrusion, and sort of broad issues like that. Excuse me. So this is a picture of a rally outside the Massachusetts State House. I think that what the sign says is "Power to Justina." This is, I think that's Justina's father, but I'm not sure, responding outside the courthouse. Well, this picture I took because it's sort of old home for me. That's the courthouse where I worked for 20 years. And this is Justina's mother being taken on a gurney from the courthouse to an ambulance after she suffered some kind of fainting spell or attack in the context of one of these court hearings, which is just a reflection of how stressful and difficult the whole scene was. So what's important about this from my point of view is to sort of understand from a broad perspective how common it is that in medicine and in psychiatry, when people don't actually know very much, but have strong feelings about things, very compelling controversies can develop. When I was an initial trainee, it was early in the era when people were beginning to recognize that many people who had been thought to suffer from schizophrenia for years actually had bipolar disorder, and so a sort of great controversy emerged at that point about, whether bipolar disorder was more common or schizophrenia was more common and how to tell the difference and so forth. There was a period of enormous attention in child psychiatry and forensic psychiatry to questions about memories of sexual abuse and satanic abuse that people reported having come back to in adulthood regarding things that may or may not have happened to them as children. And I went to half a dozen different presentations in which people just argued incessantly about sort of who to believe and what was reasonable and so forth, and none of these arguments actually had any rationality at all. It was just sort of emotion and opinion. More recently in child psychiatry, there's been a major controversy over the question of whether bipolar disorder in children is the same condition as it is in adults, and basically there's one school that is centered at a hospital in Boston that has been sort of promulgating the notion that bipolar disorder in children doesn't manifest the same way as it does in adults, and the question is that really bipolar disorder, or is it something else entirely? And of course nobody knows, but there are these enormous controversies that develop between one camp and another camp, and again, they don't have any particular rational basis. All these things basically emerge from situations where issues are important, the information is inadequate, people sort of approach the problem with particular personal and political beliefs and personal and institutional loyalties. There are institutions that sort of foster particular visions of one side or another of these controversies, and people sort of end up being allied on one side or another. But again, it's more like political argument than it is medical argument, and it has the same kind of essential irrationality and stridency that any kind of political argument has. So obviously, in all these cases, it's never true that one side or the other is completely correct. But in any single case, one side or another could be correct. It could be that an adult who remembers having been sexually abused as a child could actually have been sexually abused as a child. But in another case, it might also be true that the person was not sexually abused as a child. And this stuff is all sort of straightforward and pretty much self-evident, I think. So let's turn to the whole issue of medical child abuse, which has now become, after, probably 15 years of sort of simmering concern about what people should believe and not believe, it's become a hot area in this kind of controversy. Medical child abuse was formerly known as Munchausen syndrome by proxy, which refers to Munchausen syndrome is a medical condition characterized by patients essentially making up symptoms hurting themselves in order to present with particular symptoms that are an effort to engage medical attention. Another word for it is factitious disorder. When the by proxy is added to this term, what it means is that it's a child who is being presented for medical attention with that are created or exacerbated or faked in some way by the parent. So the parent is the person perpetrating the Munchausen syndrome by proxy or the medical child abuse. And the reason this is considered abuse is that the process involves a collusion between parents and medical professionals in which presumably the medical professionals are duped rather than, sort of agreeing to go along with this. But the result is that children can be injured by being exposed to unnecessary medical intervention, by being poisoned, by being injured directly, all for the sake of obtaining essentially bogus medical care, which is understood to be motivated by the parent's desire to establish some kind of special relationship with doctors as a sort of self-sacrificing but noble, long-suffering caregiver. Now, the difference between medical child abuse and conversion disorder is only who's at fault. Medical child abuse is an accusation against the parent that the parent has done something, whether it's faking medical tests or encouraging symptoms or providing false information to doctors or whatever in order to obtain unnecessary medical care. Whereas conversion disorder is an accusation against the child, claiming that the child has gone through some sort of odd psychological process that involves coping with some kind of stress in a way that may result in physical symptoms that don't actually correspond to ordinary pathophysiology or the way the body usually works, and so therefore they're understood to be not fake exactly, but not physically caused. They're understood to be caused psychologically. That's what conversion disorder refers to, and it's a very shaky concept that it's very hard to sort of ever prove, and it's usually almost always false. On the other hand, it does sometimes happen. Each of these positions, the medical child abuse position, the conversion disorder position, are, as I pointed out, they're both fundamental attacks on the parent's and child's integrity. Parent's motivation is thought to be attention and to establish a special relationship with doctors. The child's motivation is entirely uncertain, but theoretically it's thought that some sort of failed process of emotional coping whereby stress or anxiety gets converted, which is why it's called conversion disorder, into physical symptoms that don't make physical sense, but which may have some value to the child in terms of attention or even sort of being excused from obligations that the child may not want to take part in, like going to school or something like that. Now, as in all these controversies, either side could be right. Medical child abuse does happen. Munchausen by proxy is a real condition. I've been involved with cases where it was actually quite clear that that was in fact what was going on. It's also true that conversion disorder does exist, although I haven't had as convincing experience of that as a real process. So it's important to understand that it's not just a matter of parents and children being railroaded by doctors who don't get it. It is also the case sometimes that parents and children are faking in some way or, being disingenuous or making things up for obscure reasons that end up sort of putting people at risk. And as always, you can never say one way or the other that one side is always right. Now, why is this relevant to EDS? I think probably most of you who are listening to this will already recognize the answer to this. EDS is very much like mitochondrial disorder. It's a multi-system condition with elusive symptoms that's not well known, that involves all kinds of different problems. It's not easy to diagnose, and as a result, it's common that any of these symptoms, which are common manifestations of EDS, stomach upset, breathing problems, fainting, seizures, tremor, pain, fatigue, all these things are relatively nonspecific and are more commonly manifestations of other more common disorders than they are of EDS. So it turns out that when they all go together and they don't turn out to be the result of any of the separate conditions that are more common causes of these symptoms, doctors often will basically discount the combination of symptoms and claim that the patient is either suffering from anxiety or some sort of nonspecific stress disorder and won't pursue further diagnostic evaluation. And if the symptoms include specific physical symptoms, then that's when the conversion disorder label ends up being put into play. Now, the diagnosis of medical child abuse is an interactive phenomenon. It's not something that happens without difficult and awkward interaction between families and doctors. And it's more likely to happen in situations where parents are being aggressive, good parents for children who are suffering from obscure and difficult conditions, and they respond to the doctor's diagnosis that it's a sort of nonspecific anxiety problem or a conversion problem by getting angry and confrontational and skeptical and advocating aggressively with doctors for more testing, more consultation, an actual genuine diagnosis rather than being shuttled off, with this label of anxiety or conversion disorder. And the problem is that these things are all entirely reasonable, good parental practice things, but when they're overdone, and even sometimes when they're not overdone, they can lead to conflict between the family and the doctor, increase everyone's level of stress. They can sort of be annoying and threatening to doctors, and doctors then can respond to this particular kind of advocacy on the part of parents by not saying, well, gee, I don't really know. I'm a little over my head here. I understand that your child has a really terrible combination of problems that don't make sense, but I'll do my best to try and figure them out. Instead, they'll say, what are you talking about? You're a parent. You're not a doctor. You don't know anything. You probably are the cause of this to begin with because you're too nervous and you're too uppity and you're too annoying and intrusive and and you're just mad all the time, so of course your children are sick. I'm sure that that's a pretty familiar scenario, unfortunately, for many of you. Now, the problem with a diagnosis of, or one problem among many with a diagnosis of medical child abuse, is that it is, in fact, an accusation. It requires the doctor to make a child protection report, to open a case. This is obviously a terrible intrusion for the family, for the child. It sort of upsets everything. It's also quite burdensome to doctors, and so you would think that it probably wouldn't happen very often because, I mean, doctors don't want to sort of get involved in this kind of stuff. But surprisingly, it does happen, and that's kind of curious. When it does happen, it can lead to the opening of protective services cases, the child abuse investigation, court action, even the loss of child custody, as happened with Justina. And the one important question is, why does it actually happen this way? And I think I have another slide that I'm going to get to that, so I don't want to lose track. Anyway, this slide is about any case of child abuse, basically, or alleged child abuse, needs to be understood from the sort of point of view of four different questions. And I refer to these questions as the four H's. What happened? What harm did it cause? What help can the parents provide? And what hope is there for the future? What's remarkable to me is how infrequently even courts, let alone child protection agencies, actually address these questions with anything like the kind of explicitness and care that they really need in order to be addressed fairly and appropriately. So this is the slide that has to do with why doctors would actually pursue this sort of effort. What are the stakes? If it's true that parents are involved in medical child abuse, then the stakes are really high. The children can be physically harmed, they can be poisoned, they can die, they can suffer serious physical traumas in the parents' effort to get medical attention. And children will be inevitably emotionally harmed by the process of developing symptoms that are physical but are emotionally based, because it's just sort of contrary to normal emotional functioning and normal emotional development. And so children who are involved in these kinds of cases will suffer from the effects of learning inappropriate illness behaviors and attitudes, where they become overly dependent and they suffer generally impaired emotional development and capacities for undertaking independent challenges with their own perspectives. On the other hand, if the allegations are false, then the children are inevitably emotionally harmed because they are accused of faking, of making things up, of trying to fool people, and they recognize that the parents are accused of the same thing. The intrusion by child protection agencies or by the state can seriously undermine child-parent interactions, and the whole process tends to generate in children a really compelling defensiveness, sort of counteractive sort of closeness and defensiveness towards the parents, and a compelling mistrust of medical professionals, so that in the event that it turns out that the allegation of conversion disorder or medical child abuse is not correct and the child actually is ill, the child's access to medical care becomes that much more difficult because the child is so turned off from any kind of trust in ordinary medical professionals. And that was the story in the case that I wrote about that Deanna referred to earlier, which you'll get the reference for when this is over. So let me just tell you, there is no way to say, overall, who's right and who's wrong in this particular kind of controversy. I can tell you that in my years of working with children and families around child abuse cases in the juvenile court, I was involved with only one case of unambiguous medical child abuse, where it ultimately became perfectly clear that the child's GI symptoms, chronic vomiting and so forth, had been the direct result of, there were two children. The mother was putting ipecac in their food and causing them to be sick, and this was, I never really understood why she wanted to do that, but the theory about this is that it had something to do with her wanting to have more special relationships with doctors. I had one other case in which it seemed pretty likely that the mother was like forging or making up test results or altering test results in order to keep her child involved with a medical team and sort of be the parent in that kind of drama. But in fact, that case was never proven to my satisfaction anyway, even though it was perfectly clear that there was a lot of weird stuff going on. On the other hand, I've seen lots of cases in which children have difficult and complicated symptoms, both medical and psychiatric, in which they haven't responded to ordinary efforts at assessment and treatment, and in which, as a result of their not responding to ordinary efforts at treatment, they end up being placed in hospitals or in residential programs away from their families on the theory that somehow that kind of environment will somehow be better able to meet the child's emotional and developmental needs than the parent will, and in fact, it doesn't work. That's not to say I haven't seen situations where children have been placed in residential programs and gotten better. I certainly have seen that. But the point here is that I've seen more cases in which children have been thought to be suffering from parental inadequacy and removed from parents and placed in treatment facilities without it actually being helpful. Then I have cases in which it was clear that the parents were actually doing things that were harmful to the children. The problem when children are removed and placed in this manner when there isn't a good reason for it is that they don't actually respond to treatment. They tend to get worse over time, and when it comes time for them to return to their families, the parents and children both have a terrible time getting back on track and so forth. So let's see. So I have a few ideas about what it makes sense for people to do under the circumstances. There are a few ideas for doctors. first is, to be honest, if you don't know what's actually going on and if the evidence is unclear, it's very important to be upfront about that, to admit it to yourself and to the family, and as a first step, to get consultation from more expert medical and pediatric providers who actually have greater familiarity with the range of multi-system obscure problems that can present in these ways that tend to promote conversion diagnoses. I think it's almost always best to avoid making a diagnosis of conversion disorder, even when it may be almost certain that conversion disorder is what's going on. When I say, there probably are situations where it's actually completely certain that a conversion disorder is what's happening, and those kinds of situations are situations where somebody has a neurological symptom that has sort of some intuitive sense to it, but doesn't actually correspond to the way the nervous system actually works. So it is, in fact, physically impossible. In those kinds of cases, maybe it makes sense to go ahead and make an explicit conversion disorder diagnosis. The problem is, though, it doesn't usually help. It usually just puts people more on the defensive, increases the anxiety level. I don't think I've ever really heard of a situation where someone has offered a diagnosis like this in a way that is actually helpful and reassuring, and to which the parent would respond by saying, oh, thank God, it's not MS, it's conversion disorder. It's just a matter of, sort of doing something psychological that will help in some way. In other situations, there's almost always too much ambiguity to make it pay off to actually make this diagnosis, and it's always too accusatory and undermining and just an expression of distrust and lack of support for the patient and the family. And so the alternative that I think makes much more sense is for doctors to say, I don't know what's wrong with you, but I'm going to do my very best to figure out what it is, and I'm going to get all the help I possibly can in doing that, including from a variety of consultants who sort of know about these strange symptoms, and also from maybe some other consultants who are really good at helping people to cope with the stresses of being sick when they don't really know what's wrong. So I'm not going to abandon you. I'm not going to tell you that I can't help you. I'm not going to try to shuttle you off to some mental health professional to fix you. But I am going to stay with you and do my best to get to the bottom of it. And I want to work together with some colleagues in this process so that we can help you as a child and family to cope in the best possible way that you can with all these stresses. And in this way, you hopefully will be able to succeed at enabling people to engage in mental health support that will be helpful without being so defensive about it that they will just run away. Now, in the case of the kind of professional controversy that is at the center of the Pelletier case, there's something that didn't happen in that case, which is absolutely critical to handling this sort of thing in the right way, and I just don't have any idea why it didn't happen. But it's pretty commonly understood that the right way to deal with situations where there is this kind of controversy about a diagnosis is that professionals act professional about it, and they sort of don't promote antagonism and controversy. They communicate as completely and modestly and effectively and assertively as they can with one another about why they sort of see the case in one way or another, and they're really careful to articulate the differences of either observation or opinion that sort of underlie their different points of view. And in the process of articulating those differences, they come up with a clear, careful plan about how to proceed to address things that are ambiguous and to provide helpful care in the context of continuing uncertainty, which is a much better way to deal with things than to sort of get into a big fight about who's right and who's wrong. Now, if you're parents in these circumstances, the first thing to do is to keep your cool. It's very hard to do when you know that you're being accused of hurting your child and also of making things up and of being dishonest, essentially. But it's actually critical to sort of keep as calm as you can be under these circumstances and to be polite and appropriately respectful. Doctors really, really, really like to be respected, and many of them, unfortunately, don't do well when they're frustrated in that desire, and so they, in turn, become, defensive and arrogant and controlling and nasty and destructive. It's important to understand that doctors are human, and that means that they have flaws and they can make mistakes, and some of the mistakes that they can make can be in terms of interacting in a productive way. And so the challenge here, of course, is that you want to be cautious enough and suspicious enough to sort of maintain your skepticism and your appropriate caution regarding overreaching on the part of the doctor or carelessness on the part of the doctor, but you want to do it in a way that is civilized, calm, polite, and does not throw gasoline on the fire, because if you respond in a sort of particularly antagonistic way, you just give the medical professionals more ammunition for accusing you of being a bad parent and emotionally inappropriate and unable to provide appropriate care for your children and so forth. So my recommendation is that you recognize that, in fact, as unfair as it is, in these kinds of situations, doctors actually have much more power than parents do, and therefore, if you really try to fight it, you're probably not going to win. But on the other hand, where parents do have the power is with regard to their children and their autonomy over their children's care. And so if you feel as though what's going on is that you're being disbelieved and disregarded and suspected and accused, really the right thing to do under those conditions is to avoid the struggle, to nod politely and say, "Thank you very much, doctor, for your opinion. Of course, I'm not sure that I agree with it, but I'm very respectful for the care that you've brought to dealing with this very difficult circumstance. And I'll get back to you, but for right now, I think I'm going to go and see if I can find another doctor." And That's not a terribly satisfying answer, but it's the best I can do. And so now, any questions or discussion, I'm ready to deal with it.
Okay, thank you, Doctor. That was very informative, and that is something we've been hearing in the news more and more about individuals that are being accused of child abuse, and it's very difficult for parents as they are working with their children and trying to find them care. So thank you. This has been very good advice, and we do have a number of questions, and you can feel free to click on the Q&A box. And what I propose that you do is there's a little button arrow down at the bottom, and that would probably be easier for you to sequence through rather than use the scroll bar. And if you could read the question and answer it as best you can, we certainly appreciate it.
All right. So you want me to take these in order rather than trying to review them? And
well, as you go through, if you see some that are duplicates, then obviously you can combine them. You can summarize them.
Okay.
However you feel is appropriate at this time. Okay. Excellent. Thank you.
So the first question here is from Lisa, who asks, do I have any thoughts regarding the recent news reports about a depression blood test and or how that might pertain to EDS? And the answer is I don't have any thoughts because I don't know what the depression blood test is that she's referring to. I do know that as far as I'm aware anyway, there isn't any definitive blood test to diagnose depression. There are some physical tests that do tend to be helpful for contributing to a diagnosis of depression, but basically a diagnosis of depression is based almost entirely on a combination of good history taking and good symptom description. And so the role for physical diagnosis, or chemical laboratory diagnosis, whatever, in that process is pretty limited. Now, I guess I can infer from the question that you're interested in the possibility that a blood test like this might in some way help to differentiate between sort of ordinary depression and some collection of symptoms that's actually related to EDS that presents similar to depression, like, for example, fatigue, breathlessness, fainting, pain, the kinds of things that sort of go into a diagnosis of depression but actually stem more from EDS. And if that's the question, certainly if there were a specific blood test to discern the actual psychiatric condition of major depressive disorder, which probably is a real condition, and it were positive, that would be important to know. It would be important to know whether or not the patient also had EDS, because especially because if a test like that were positive and the person had EDS and was being understood as suffering from the depression-like phenomena of EDS and therefore wasn't actually being treated for the depression, a positive test would encourage relevant treatment for the depression. On the other hand, I don't think it's true that a negative test in a similar situation would sensibly turn someone away from the thought of treating the depressive symptoms, because I think regardless of whether the symptoms are manifestations of a sort of separate depressive process or from EDS, many of the same treatments are likely to be effective. So I'm sorry I don't have more intelligence to say about that. All right, so the next question is a long question that also has to do with how to help a loved one who has battled many years of being told that it's in your head and ends up not trusting the medical community as a result. Treatment hasn't been helpful, and the underlying problem isn't really understood. And the ultimate diagnosis may actually get made, but it's not doesn't sort of fall on happy ears by the time it gets made, and many mistakes may have been made in the process. I think the answer to that is just to be sympathetic and realistic, and like any other situation where you want to be helpful to someone who's had difficult experiences, you sort of acknowledge the reality of the difficult experiences and offer help and support, and then do what you can to help the person to sort of try and figure out whether there are any actions that the person can take that would actually make things better. And again, that's a pretty non-specific answer, but all right, so here's an interesting question. Let me just read this. When it's said that Justina's family fostered illness behavior in her, I see severe victim blaming and a grotesque application of family systems theory, i.e. that Justina is deliberately ensconcing herself in a victim role and her parents are codependently enabling her, artificially creating drama. Can I speak to the application of this already fairly questionable treatment model when it comes to genuine medical crises? Well, the answer to that is it's self-evident. It's within the question. Of course, it's a theory. I mean, all these family systems theories are nothing more than theories, and the truth is that, with the exception of theories that basically derive directly from the science of operant conditioning, interactional theories about family functioning may have a lot of value for certain families and certain therapists in certain contexts, but it's mostly in that they allow for the development of metaphors that enable people to sort of communicate more effectively about problems that are actually bothering them. And it's not like they have any scientific value or any actual descriptive value for what really goes on. Basically, I would just be very skeptical. I mean, what ought to happen in a situation like this would be what I picture, and what never did happen, to my knowledge anyway, would have been that the people who were arguing for the medical child abuse theory would be called into court and examined and cross-examined by people who really knew about family interaction and medical care and psychology and psychiatry, and it would become immediately clear that they just didn't really know what they were talking about. They're just making stuff up. But obviously that didn't happen, and it rarely does happen, although it would just be wonderful if it did. What's the best course of action when a doctor doesn't believe you or your child? What is the best course of action if CPS is called? Well, I think the best course of action if a doctor doesn't believe you or your child is to, first of all, recognize what's going on. That you're basically being disbelieved, and maybe it's worth sort of trying to figure out if there's some way that you might be able to sort of make the case more strongly. But there comes a point where it should become pretty clear that that you're not getting through, that you're not being believed, that you're not going to be believed, and that it just isn't working. It's just a relationship that is not going to end up being helpful or productive in dealing with the troubles that you have. And in that case, the best course of action is to give up. You don't keep beating a dead horse. You don't try and try again if it's just going to sort of make things get worse. And so the thing to do is to say, well, okay, I understand that we disagree, that you think that something else is going on, that you're not hearing me or believing me. I think that that's unfortunate, and but you're the doctor. I'm the patient. This isn't. On the other hand, what you're offering isn't helping me. So, if you'll excuse me, I think I'll just go and find another doctor. If CPS is called, then the best course of action is to sort of begin by, well, I'm not actually sure what the best course of action is. I think the best course of action, I guess it depends a little bit on what the circumstances are, what the stakes are. I think the best course of action would probably be to sort of hear the person out, try and understand what the concern is, be cautious about what you say. Think of it as comparable to, an arrest and a police interrogation. And if it seems that there's a simple misunderstanding that you can sort of easily take care of, then it may be a good idea just to sort of go ahead and politely try to take care of it. But it's important to understand that that these things can go bad, and that there may be things that will happen that are sort of beyond what it's reasonable to expect. And so I would have a low threshold in any circumstance like this for contacting a lawyer who actually knows something about child abuse cases and maybe even mental health cases, and getting some advice before proceeding to participate in the investigation. So the next question, have you seen in your practice adults who were neglected or physically abused as children and then present with increased pain syndromes or medical problems? Yes, of course. Can our childhood affect our body in adulthood in ways that medicine cannot identify yet? I think so. Yes, definitely. And there's there's all kinds of recent research about the physical effects and the developmental effects of child abuse on young children, and it's not just physical abuse. It's neglect. It's any kind of high stress situation that basically contributes to sort of early dysregulation of the what do you call it? The cortisone, adrenal axis, the body's way of managing stress, coping with stress. It gets all out of whack, and so there can be compelling long-term abnormalities in what the kind of autonomic regulation of stress situations as a result of early exposure to child abuse. And I don't think that we're yet at a point where it's possible to say, what the physical manifestations of those difficulties are most of the time, or whether they may or may not contribute to vulnerability to other kinds of longer-term medical problems. And so again, I don't know the answer to that. It would just be speculation. We're not there. I'm sorry. This is a long question, and it basically has to do with the challenge of having EDS and not being taken seriously, and then sort of encountering people who may sort of overdo it. And I don't know. I mean, this is a complicated question that I think is sort of it's too individual. I'm sorry about that. The next question is: have you seen a correlation between EDS and dissociative identity disorder, or DID? Dissociative identity disorder is the new psychiatric term for what used to be known as multiple personality disorder. And I have not seen such a correlation. I haven't looked for it. And then the follow-up question is, how prevalent is DID among EDSers? And I have no idea what the answer to that is. I think that that it's essentially an unanswerable question because in order to answer that question, you would have to know how prevalent DID is, period, and you would have to know how prevalent EDS is, period. And I think we don't actually know the answer to either of those questions because they're both conditions that are elusive and hard to pin down. And but it's a really interesting question. But I wouldn't be doing a good job by taking the time to sort of spin out theories about because it would just all be speculation. How frequently does Munchausen by proxy occur, and how often does it turn out that the child, in fact, has an odd, rare multi-system disease like MIDA or EDS? know the answer to this, but my gut answer would be that it actually, well, the problem with figuring out how commonly Munchausen by proxy occurs is that it has so many different forms and it has sort of different kinds of definitions. If you define it as a condition in which parents are seeking inappropriate medical care as a result of causing injury to the child, physically or by poisoning or whatever, I think the prevalence is much lower than if you define it more broadly as a condition in which parents are causing injury to the child by, stressing the child out and, sort of causing anxiety and sort of fostering inappropriate illness behaviors. But at any rate, my gut answer to this question is it doesn't occur very often, at least when it's defined more narrowly, which is the more appropriate definition, because after all, everybody, when their child is sick, gets stressed, and nobody responds perfectly to the stress that their child's illness causes, and everyone, as a result, ends up causing some additional stress and difficulty to the child that is just a sort of ordinary consequence of the child being ill and everybody being under stress. So I think if you define Munchausen by proxy broadly to include that kind of process, you're just not. It's not useful. It's not anything that's other than just ordinary life with a sick child. How often does it turn out that the child, in fact, has an odd, rare multi-system disease like MIDO or EDS? We don't know the answer to this because nobody studies this. It's a wonderful question, and it would be a great question to research if someone is interested in, like, sort of trying to conduct some kind of survey of child protection agencies or pediatric hospitals or providers or anyone who would presumably be in a position to know things like that. But I don't know how else you'd be able to know the answer to that. And even then, the definition questions would be so difficult that the actual factual knowledge that you would get from doing it would always be open to question. If your doctor is interpreting symptoms as mental illness, how can you get them to be more objective and continue the search for a medical diagnosis? Well, I think the answer to that is that you don't argue about it. You acknowledge, well, yes, I have this and that. Yeah, I'm depressed. I'm nervous. My life is bad, and of course I have these symptoms. But I think that if you look carefully at my history, you'll notice that ideally you'd be able to sort of point out to the doctor that there's something that in the history that doesn't sort of jibe with the idea that it's just a mental illness, and you try to sort of engage the doctor in an intelligent conversation about it, and avoid allowing yourself to be drawn into an argument. You want to try to establish a relationship with the doctor that is collegial, where you respect the doctor for what the doctor has to offer, and the doctor respects you for your knowledge of yourself and your history and your emotional circumstances. And if you make your best effort to do that, and the doctor doesn't get it, then I think you're probably not working with the right doctor. Do you know the process for implementing legislation that promotes a second objective opinion and appeal rights while checking in on the child for signs of harm? Appeal rights while checking in on the child for signs of harm to the parents. There should be a process, I think, to do no harm. So, the process for implementing legislation like that would simply be to collect people who are interested in furthering that kind of legislation and present it to a legislator and get the appropriate kind of institutional support from medical professionals and legal professionals and child protection people to recognize that the sort of standard routine of child protection investigation is far less than ideal and sort of leaves really complicated questions open to the sort of relatively inexpert assessment of people with bachelor's degrees in social work, without sort of any sort of particularly good oversight, at least a lot of the time. The problem, of course, is that to do it better would be really expensive, and you would have to, it seems to me that to make it realistic, you'd have to sort of craft a plan that would limit the second opinion approach to situations where the stakes are high and where the facts are ambiguous, rather than having it be sort of constantly available. On the other hand, as I hear myself say that, I think that's stupid. Everybody ought to have the opportunity to get second opinions and to appeal these circumstances. And if you're living in a situation or in a place where that's not part of the usual routine in the child protection area, then that's too bad, and it would be wonderful to be able to find support for pursuing that kind of legislation. What do you recommend when you encounter a doctor who questions your diagnosis? Address it with him or move on to another doctor? It's hard as a nurse myself because as an advocate for patients who might follow behind me, I want to address it, but sometimes I know there's no point, and for my own health I need to move on to someone who may be more productive in terms of serving me as part of my medical team. So, sure, it's always a personal judgment. You sort of do your best, you sort of try to be thoughtful and helpful to the doctor as you are sort of working on developing this colleagueship with the doctor regarding your concerns. And if it turns out that the doctor's just not listening, then you're not going to help. You do yourself more harm, and you're not going to actually help people who come after you. You might help them more, actually, by raising thoughtful questions and being friendly and supportive to the doctor and helping the doctor to sort of ponder those questions after you leave and find another doctor. What about, wait, I skipped over some things here with the school bar, I'm sorry. I was supposed to be able to do this with not the school bar. Okay. What about children with EDS and autism who cannot speak out or they are misinterpreting what is happening to them? the bruises, the subluxations, dislocations, etc. As they get older, even having to keep them on a special diet. This is a child who can speak, very high functioning, but thinks EDS is fun, but doesn't understand his emotions. When CPS is called, they're even more confused. Well, yeah, that would be confusing, and it sounds like a really challenging circumstance. I guess the only thing I can say to that is that ideally, dealing with that situation would involve getting the help of people who actually know a lot about both EDS and autism, and also about autism and emotional functioning or dysfunctioning, and who can sort of be helpful to the child in question in coming to recognize emotions and the reality of the condition. Also helpful in explaining all those things to other people who are involved and who are also puzzled by the case. Do you have an article or flyer that is helpful for doctors who are having difficulty understanding a disorder they haven't had much interaction with, or that presents in a wide array of confusing symptoms? I don't, but the websites for EDNF and for Mito Action have all kinds of things like that are really helpful for people to be familiar with and to have in their possession and to share when they're dealing with doctors. Due to years of not being believed or taken seriously, I now am very sensitive to this during appointments. It's probably one of my biggest worries. I try very hard to go into each new appointment with an open mind and assume that the doctor will take me seriously, as for the most part they do. However, I still feel extremely hurt and upset when I am not taken seriously, that is believed, or easily dismissed. I only go to the doctor when it's warranted, and I would never lie or exaggerate my symptoms. Of course, the doctor doesn't know me and who I am as a person. How do I not get so personally hurt and upset when this happens? Most people can shrug these things off and say, he's just dumb or he doesn't get it. But I am more sensitive, and I feel like I must be a horrible person to not be believed. What can I do? Well, I think that, it's important to sort of give yourself the best foundation you can, and recognize that in spite of the fact that you know what the trouble is, other people may not. It can be really helpful to have good documentation with you. I have a patient who has mitochondrial disorder and has developed over the years an elaborate, what she initially referred to as a user manual for her conditions that she would sort of present to medical providers. I think it can be helpful to have that kind of material with you. But the other thing is that, being sensitive and easily hurt doesn't mean you're a horrible person. And being not believed doesn't mean you're a horrible person. You sort of do the best you can to present yourself, and, it's a two-person interaction, and of course it's frustrating and demoralizing not to be believed, but but if you just remind yourself that it's a part of the game, and ideally limit the necessity to have new doctors. I mean, one of the things that's most helpful is to sort of gather a collection of doctors that you can trust and that get to know you over a period of time, so that you don't end up having to sort of deal with people who don't know you at all, ideally. So this question is quite general. In the course of my social work career, I've worked on federal legislation and also worked in CPS. What are changes that you would recommend being made at both levels, that is, federal legislation and child protective service practice? Well, I think what I would recommend is that I don't have any idea about federal legislation or even the federal sort of legal context that affects child abuse. And I don't have any particular sort of recommendations to offer for child protection service practice, other than that workers get paid more, have fewer cases, get more help and supervision and support and consultation among themselves and with experts, so that when they're dealing with complicated cases, they can sort of not feel overwhelmed, and they don't have to cut corners, and they can take the time to figure things out. But again, that takes a lot of money, and it takes a genuine public commitment for that sort of thing to happen. And in my experience, those conditions don't exist very often. So if your doctor doesn't support you, doesn't believe you, and then you switch doctors, often that is a red flag and called doctor jumping. How do we avoid this while seeking proper help for our child? I think the answer to that is that you sort of recognize that it's a potential risk, and when you show up at a new doctor, you make clear that you've been to a number of other doctors, and as nice as those people may be, they haven't actually got it right, and you as a parent are doing your best to find the best doctor for your child and your child's problem, and the notion that someone should trust a doctor just because the doctor is a doctor when the doctor doesn't get it, and continue to submit to that doctor's care, obviously makes no sense. And I think if you can just sort of feel confident that that makes no sense, and sort of approach the new doctor from the idea that, well, I'm jumping doctors, the other doctor didn't get it. It's not, if you just be confident about it, I think it should be okay. How do you deal with a doctor who says, this is a bogus diagnosis and they just told you that to get rid of you? I think, so this would be in a situation where you are seeing another doctor and explaining that you got this diagnosis from somebody else. I guess what I would say is, well, I don't know that it's a bogus diagnosis, and if they were just trying to get rid of me, I think it would have been better for them just to say, we can't help you. Okay, my child is 13 and along with EDS and POTS is suffering from chronic neck pain. He's frustrated, but I think coping very well. We have seen 3 different psychologists because our doctors say he needs help with his stress anxiety. But we aren't finding any help from these professionals. We have so many doctor appointments weekly. Should I continue to try to find a therapist? How do I find one that can actually help? That's a really important question and really common. And how do you? And the problem is that it's not easy to find therapists who are actually helpful with these kinds of problems. I guess, I guess what I would recommend is that you talk with other people, other parents who have had similar kinds of concerns and who may have had better luck in terms of finding someone who's been helpful. And if there are other doctors who you actually are working with, who you trust, who you think would be able to offer good recommendations, you can certainly ask them. But I'm sure that's what you've done already anyway, and it hasn't actually worked well. So, sometimes to find a good match, you have to try a lot, and it's not easy to do, especially in these kinds of situations. And it does have to be a good match. You have to, if therapy is going to be helpful, it either has to be a really specific kind of psychotherapy that doesn't really require any particular empathic understanding or strong sort of emotional connection between a doctor and a patient, like CBT in some circumstances, or it has to rest on a relationship where there's genuine comfort and trust. And those, unfortunately, aren't that easy to find. When feeling blocked by a doctor, medical professional, when you're getting the "it's all in your child's head" attitude from them, what can you do to keep yourself and your medical record from being damaged by their bias? I don't know that there's anything you can do to protect your medical record unless you want to go to the trouble of asking the doctor to take something out or change something, and you may be able to do that if you can come back at a later time with an actual physical diagnosis, but often doctors may not be willing to do that. I know that a lot of people are really concerned about how conversion disorder diagnosis can poison the perspective and opinions of doctors who encounter the record later on and see that diagnosis and then sort of develop skepticism and so forth. I'm not. My own opinion about that is that I guess it happens, but I think I have a little bit more faith in the objectivity of most doctors and the recognition of most doctors that, just because somebody at some point in the past has offered a conversion disorder diagnosis, that doesn't mean it's true. And I would sort of hope that most doctors would have sort of a more healthy spirit of competition than that, and they would see that kind of entry in the record, and they would say, I'm not going to fall for that. I'm going to find out what's wrong with this person. But who knows? I don't. There are very few neurosurgeons in the country that are EDS experts as well. So, did a bad thing with the school bar. There are very few known neurosurgeons in the country that are EDS experts as well, so many of us have to travel many miles, states or across the country for help. This can also be seen as a red flag, but what else are we to do? The experts just don't exist, but these small handfuls. Of course, what else are you to do? I mean, I sometimes find myself worried that the establishment of a community of educated patients and expert providers will sort of, like there is in the EDS community, will sort of come to be seen by the uninitiated as sort of community of quacks or enablers, and it seems to me that that's a significant risk. But what else are you to do? I mean, you do have to sort of get help from people who know what to do, and so I think the challenge is sort of being able to tolerate the possibility that people who don't understand are going to sort of see it in the wrong way, and you just sort of shrug your shoulders and say, well, it's what we have to do. I don't think there's any other solution to it. It certainly, given how far we still are from establishing EDS and related conditions as part of the sort of ordinary sort of repertoire of medical knowledge, I think there just isn't any other way to deal with it. And so the challenge is, in individual situations you have to do it, but more importantly, the idea is to foster better and better understanding in broader and broader parts of the medical community, so that these things, don't get seen as red flags, but they get seen as good judgment by people who need help from experts. What about providing documentation to doctors and they don't want to read it? They act like they know it all. They are misdiagnosing, even when it's brought up by other medical professionals. As a parent, they know you know more about the disorder, but they don't want to look incompetent. How many times do you go back to them? Well, if you know that's what's going on, I wouldn't go back to them one time. I would go to somebody else. I feel most EDS patients have been left to learn about EDS and related disorders on their own. This means many of us know a lot about the conditions. Obviously, those two sentences are inconsistent with each other, because it's not as a result of learning on your own, it's as a result of learning from other people who have also learned it and are willing to share their information. What is the best way to approach doctors who don't know much about it, such as in urgent care, without looking like we are making things up or trying to find things that aren't there? For example, my daughter has been accused twice of having a panic attack when we went to our local ER for her POTS. So, again, this is the unfortunate reality of suffering from a condition that is not part of the standard range of things that most ordinary providers understand. And I think the best way to approach it is to be modest, non-defensive, thoughtful, generous to the doctor who may not understand, willing to share the information, but also sensitive to the possibility that the doctor may feel awkward in that interaction because the doctor's not used to being taught by a patient. again, this is all part of the problem of developing a colleagueship. I'm not a parent. I was brushed away with conversion disorder by a neurologist who did not see anything on my MRI. It turned out to have CCI and am now being checked for a Chiari. My question is one of need for an advocate and who I could go to help me in these situations, like an organization. I'm too tired to change doctors. It's a big process with my insurance. Ideally, organizations like this one are able to offer that kind of advocacy. The other organization that I'm most familiar with is TCAP, the Coalition Against Pediatric Pain, who has a lot of people working as volunteers and are able to help with these kinds of situations. But it seems to me that the fact that you're taking part in this webinar at all means that you're involved in a support group, and so there are other people that you're in contact with and who could probably be able to help you in that regard. When they ask you to do party tricks and you have documentation you cannot do that, why can they tell you you're not compliant? How can we avoid this without causing ourselves harm? I assume this means that doctors will sometimes in the process of doing a physical exam ask you to do things with your joints that are extraordinary in terms of your ability to do them, but they're not good for you, and so you would prefer not to do them. I think in those circumstances, you just have to say, I can tell you what would happen if I did that, and if you want to look at my past records of when I did those things before and demonstrated my strange abilities, that would help you. But I don't want to put myself at any further risk by going through this routine at that point. And if the doctor is reasonable, the doctor will understand that. As a parent of a child recently diagnosed with a psychological condition I dispute, what is the best way to work with future caregivers that will see that diagnosis to steer them toward EDS-related treatments? Well, I guess the answer to that, I think, is to have as good documentation as you can of I assume what you're referring to here is that the disputed psychological condition is a psychiatric diagnosis rather than an EDS-related diagnosis, such as panic disorder rather than POTS, for example, and that in that situation what you would need to have is the best documentation you can for the presence of the EDS-related condition and the need for EDS-relevant treatments. Again, be prepared to play the part of a teacher, even though you would prefer not to have to do that. Do you find women are at a disadvantage than men in the medical field when it comes to going with the child? Should both parents be there? I actually don't find that women are. I assume that this means women as mothers as opposed to men as fathers, and I don't see that as a disadvantage. It seems to me that mothers are usually the people who deal with medical providers, and so I don't think that's a disadvantage, but there may be some sort of I mean, it's entirely possible that there's some kind of sexist issue that sort of contributes to this overall problem that I haven't thought of. Certainly, it's always an advantage when both parents are there. Both parents together, add more information, much more perspective for the doctors about the family circumstance and things that have happened and so forth. It's always better for both parents to be there. So this is a question from somebody who has POTS with intermittent very high heart rate, a need for emergency treatment for IV beta blockers, cardioversion, and then a diagnosis of anxiety with treatment with Ativan and being sent on her way. So the question is, how do I ensure that I receive adequate care when I absolutely must be seen in the ER to stabilize my heart rate? I have a history of depression, so unfortunately this impacts the care I receive. I'm never rude, I'm never argumentative, I just end up going home extremely hurt, upset, and frustrated, still struggling with symptoms. I think the only answer to that is to, collect the documentation that you probably already have and be prepared to share it and, be maybe more assertive than you're comfortable being in making clear to providers that what you've got is in fact a well-defined condition and it's not just anxiety and the treatment is not Ativan. And you need life-saving cardiac care under the circumstances. And when you put it like that, seems to me that most doctors would probably pay attention. Listeners brought up the concern of looking out for doctor shopping. Any advice for patients in this situation? Well, again, the advice is to not be ashamed of doctor shopping. Think of yourselves as educated consumers who, are looking for something that's actually going to be helpful and understanding that, not all doctors are the same or can do the same kind of thing. And if you approach the problem with confidence and assertiveness, but at the same time with, a sort of respect for the doctor's feelings, I think that it shouldn't actually be a problem most of the time. I'm being treated with medication for anxiety, depression, and neuropathy, in addition to mast cell activation disorder and pain related directly to EDS. When doctors see the list of medications and symptoms and diagnoses, I think they don't always take me seriously, even when what I am seeing them for may be an entirely different and empirically evident condition. Can you suggest a way to address doctors that heads off the knee-jerk reaction that this patient is a nutcase? Well, I think what I would recommend, again, this is based on the success of the patient I have who's, got, a dozen conditions along with mitochondrial disorder and who experiences this sort of thing all the time. I think the thing that works best is to, again, to be knowledgeable and confident about the reality of your own condition and just be straightforward about acknowledging that this list of medicines is imposing and the list of conditions is strange, but it's what you got and there isn't anything you can do about it, and you do have this other thing which is probably unrelated that they need to pay attention to. How can those of us who need to seek urgent care several times a year keep from being labeled as a malingerer? Well, again, I think the answer to that is you just need to be prepared to head it off, to preempt the label, to sort of go in and say, well, here I am again. You know, I've got this problem that unfortunately, you know, keeps coming back, and it's making me really unhappy, and I don't want to be here, but I need to be here, unfortunately. And here's why. I've got all this documentation. Is it out of line when receiving urgent medical care for dislocation subluxations to request custom splinting, i.e. orthoglass, or splinting in general, even if the doctor thinks it's only a pulled muscle? I don't think it's out of line at all to request something like that, especially if you know what the trouble is and the doctor is getting it wrong. All right, so that's the end of the questions list.
Thank you. Thank you, Dr. Barnum, for being patient with that long list of questions, and we really appreciate, you know, how thoughtful your answers were, and all of the wisdom that you gave us. I know a lot of situations can be very challenging for the patient.
Well, again, I'm sorry that you know, I didn't have more definitive answers to most of these questions, but they are really hard ones, and the reality is that there aren't definitive answers to most of them, and that's essentially, you know, what the problem is for this whole situation. So thank you for inviting me. It's been a pleasure, and I hope it's been helpful.
It's been extremely helpful. Thank you so much for all of your time and patience with all of our follow-ups on this.
Okay, thank you. Good night.
Yeah, I just wanted to remind the group that we will have our next presentation on October 2nd, and that be Kathleen Kane, who will be talking about filing for disability. The recording for this presentation and the PDF of the slides will be posted on the same announcement page that you use to log in. So that will be posted tomorrow. Give me until around noon. And I wanted to mention that we do have support groups on our site. There's over 60. We have 2 in Australia. We're starting one in UK and New Zealand. And those support groups typically have lists of doctors, and I would recommend that you contact through the contact page on those support groups in your area and see if you can find doctors that might be useful for you for the particular areas that you're looking for. So again, thank you for your patience, and again, Doctor, we appreciate your very insightful presentation and answers, and we'll call this an evening. So thank you, and everyone have a good evening. Good night.
Good night.
Good night.